welcome everybody to today's event, a look at and feedback into the 10-year National Mental Health Strategy /Plan. There have been a number of events across the county that's been delivered by Hertfordshire Partnership Foundation Trust and also through the collaborative. And Ed will talk a bit more about the work of the collaborative and a bit more about how they're feeding into this process. I'd like to thank you all for attending today and thank all those people that are attending online. So on that note, if I just pass on to Ed,
yeah, of course,
quickly, and then they can talk about the National Mental Health Strategy and the Learning Disability, Mental Health and Autism Collaborative.
Fantastic. Thank you, Leslie. Nice to see everyone, and hello to people who are online as well. So my name's Ed Knowles. I've got one of those really long job titles. I'm Development Director for the Hertfordshire Mental Health, Learning Disability and Autism Collaborative. So I might just say collaborative from here on in, basically. But long story short, what is the collaborative? Well, I've got this around my neck, and it says NHS, but the collaborative is more than just one organisation. So the collaborative is Hertfordshire trying to bring together all those different organisations that we think are important about supporting people with mental illness, with learning disability and with autism. So it's not just the NHS, although it does involve all the bits of the NHS. So it involves Hertfordshire Partnership Foundation Trust and the Mental Health Trust, but it also involves the hospitals, it involves our community health partners, it involves GPs, but it also involves people beyond the NHS, so social care, so the county councils, it involves our voluntary sector. Leslie's on the board as well, so the voice of people with lived experience as well. So it's trying to, as you would hopefully expect, recognise that some of the problems we have to face and some of the things we have to deal with can't be fixed by any one organisation or any one bit of this system that we work in. And so that's what the collaborative is trying to do. This strategy comes at a really good time, I suppose. So this is a government strategy. This isn't the collaborative strategy. This is national government. Looking for, suggesting that they want to do a 10-year plan for mental health wellbeing and putting out some questionnaires and some particular areas they'd like to have feedback on in terms of ideas, evidence, some discussion, so that when they actually sit down and write the actual document, that's helping to inform what they're going to say. So the events that Leslie referred to already have been trying to get as many people as possible across Hertfordshire and as many organisations as possible to have a look at this document, to look at the questions they're asking, to feed it back in. And our hope is that if we put in, is that the more we say, the more we give government, the more likely that some of our ideas will actually appear in the eventual strategy. No guarantee. They can say whatever they want to say, but we do want to make sure that the kind of experience of people who work with people with mental health, the experience of people who have had mental illness and have recovered from it or are still capable with it right now, is part and parcel of what we're saying back to government. Otherwise, it just becomes people like myself sat in an office writing things. And I may be right, I may be wrong, but who knows? I probably need to know. I need to hear from more people. The club needs to talk from more people, and certainly Viewpoint too. So really, that's the purpose of what we're doing, I suppose, today and across the other events, to try and get as many voices involved in making this response to government. It's not just a national strategy that we're working on as well. There is going to be a local Hertfordshire-wide strategy. And actually, these same questions should be the same questions that tell us about what to do locally as well. So in feeding back today, you're hopefully not just giving us material that we can let the government know about, but material that will change how we do things in Hertfordshire as well. So like I said, we had an event like this last week or the week beforehand, and had some fantastic feedback from that. I suppose two things. One last thing I would say is the more we know, the better, basically. So really, whatever you're thinking about, what the questions that we're talking about today, say it, because if you don't say it, we'll never hear it. And if we don't hear it, we can't say it back to government either.
What's the timescale on the strategy?
So that's a really good question. So this whole national process finishes this Thursday. 11:45 p.m. So we've got quite a few people having to write stuff before then. So I'm hoping not to be up at 11:44 writing it. So that's the deadline for the national.
And then when are they supposed to be reducing stuff? Is that a never
I wish I knew. I mean, the hope has to be that, I suppose it's a little bit of it depends on how much they're receiving, but I think the intention is to do it over the course of this year. And a 10-year strategy is, sorry, I'll go on and on.
No, I think it's important.
A 10-year strategy, 10 years is really good because it means they can be ambitious. so they can think about what
When
they
do
want
they
to do.
do it?
Well, there have been national strategies prior to this. I don't think there's been a previous 10-year strategy. There's been a number of national strategies beforehand. And I suppose one of the comments that was given back to me by someone who participated in our most recent event was, what's the reality that this is going to have any influence? Well, actually, previous national strategies have introduced changes that actually work on the grounds in Hertfordshire right now. So
Yes. The IAP service.
IAP service came from a national strategy. The mental health support teams in schools right now come from a national strategy. So, I mean, you can be more or less cynical about these things, but I think that the fact that they decided there's going to have a strategy, the fact it's going to be a 10-year strategy, fills me with a bit of hope that they're going to come out and say something quite important. And the other bit that makes me hopeful is the kind of the question that they've asked, because it's not just about mental health services, and certainly it's not just about mental health services provided by the NHS. It's about wider well-being. It's about wider well-being of the population, the mental well-being of the population, not just when people fall unwell.
Yes.
So how do we prevent people falling unwell? How do we make society feel healthier mentally overall? And so that's kind of hopeful that the kind of stuff that I think people like Leslie have been saying for years and years and years is clearly getting through somewhere, because the questions they're asking suggest they're thinking about that too.
Yes. Well, the strategy is named the Mental Health and Wellbeing Plan.
Yeah.
So you can see wellbeing plays a pivotal role in how they shape the new strategy.
Yeah.
So I would say that it's absolutely essential that the voices of lived experience is heard through this process, as well as other voices. I mean, we talk quite well about making sure the voices of frontline workers are heard as well, because they're often the frontline, they're often the people that engage with people with lived experience of mental health. Often it's really important to hear their voices, hear what their challenges are, and also what good practice they can bring out of the work that they're doing as well. So as I'm doing this, you will notice on your agenda, down the bottom of your agenda, that, and for those people that are online as well, I believe that Stephen has put this in the chat, there's a Padlet link. Now, Padlet is a way of you being able to put your comments online. And so I'm giving that opportunity to put, if you find that you don't have all of your comments aired today, you can use the Padlet to put your comments online. And I think it's a very useful tool. And it's broken up into themes. You'll see that's commensurate with the chapters of the mental health strategy. So the first session, I've said, will be positive mental well-being and prevention, because I think that's really important. And again, that's about all of the community, not just the NHS. The second session will be supporting people with mental health condition to live well, which I think, again, is about us thinking a holistic view of how we do that as a collective. So if I start the first session, I think would be helpful with us looking at positive mental well-being and prevention. I think in relation to what happens in Hertfordshire at the moment, what would we like to see? What differences would we like to see? Actually, what works well as well, I think is really helpful. What works well, but also what would you like to see in terms of prevention and promoting mental well-being? So I might start this. So GPs are, and I say GPs, but primary care, but I'll say GPs, are taking a much more active role in promoting mental well-being. And so their active role means that you shouldn't, I'm not saying you won't, but their interventions are helping to stop people getting into crisis.
I think just from sort of experience, it's just about, there's so many things out there, and it's knowing the pathways and how to access a lot of that help and support.
Yes.
It's a tricky bit in reality.
So it's about communication and information sharing.
Yeah. And how the agent, organisation, you just talked about, lots of different people involved, but it's how they work and who you go for one thing. And that's often been a difficulty for us as a family to know where to go.
It would help if their names were recognisable and easy to find, easy to think about, easy to Google. There's no way on earth that I would start thinking about I can't even remember what the local mental health trust is called. And if you Google my local mental health trust,
comes up with lots. Well, I think that's really important. I think the idea of knowing exactly where you can get a service, when and how is important.
Well, I'm also looking for jobs. I'm looking for jobs, and again, I haven't a clue what the local trusts around here are called.
So, because there's also something else, though, because it's really important to convey the message that mental health support is much wider than just the NHS. I think Ed eloquently demonstrated that in his introduction, that there are other organisations that you can find work with that do provide support for people with mental health issues. It's just worthwhile saying that. But it is important that that message is conveyed widely. So it's about how do we communicate about services.
Sorry. I mean, to me, one of the great crises at the moment is the GP practices. It's very hard to see a doctor. They nearly try to push you away. That's my own experience. And their knowledge, I think, is very minimal on mental health.
Yeah.
Yes, because I think we live in a nostalgia for the National Health Service, and other countries are much more progressive.
Can I ask a question? At primary care level, do you need to be seen by your GP, or could another clinician see you?
As long as they've got they are clinicians and not like my surgery now, they have what they call a social prescriber. And, well, I'm sorry, I can't see that working at all. Because they have no experience. My son's got one, and I've seen her twice and haven't seen it. Great to start with, you can get flooded with things, and the next minute there's nothing, absolutely nothing. My son is no good for him like that. Yeah, he's seen so many people over the years that was assigned to him in 2019. We're going to meet her next week. That's all in 4 years.
Yes, it is. Just can I just ask a quick question? I overheard the question being asked of you. Did your son have contact with I'll come back to the social prescribing. Did your son have contact with the social worker in that time virtually?
No.
So there was no contact in the 4 years? Phone call?
No. In the end, it was the learning disability team. Because Craig's got a dual diagnosis.
Okay.
The learning disability team, they did an assessment for his autism, and that was the final assessment.
Okay.
It doesn't get any. Well, they stayed on board because of what happened with the social worker. That she didn't make contact. She was either on holiday or she was sick. That was it. Whenever I tried to get in touch, were the two things that happened. And it was down to the speech and language therapist that has been with Craig and Dr. Rose. She was going on maternity leave, and she still kept in touch with me because she was not afraid, but she had a feeling that things weren't going to happen.
Yes.
About Craig getting to see this person. So the learning disability team really sort of said, you really need to do, in a word, job.
So
you need to make contact.
Yes.
So we have made contact, and we will be seeing her.
Could I just ask a quick question? Your son has autism as well. Is it autism that he has, or autism and mental health, or?
He has autism and learning disabilities.
Okay.
And there is, I've worked, as I said to you, many, many years for the NHS. And one of the things that was quite positive years ago was when the NHS said that people with mental health problems will also have learning disabilities. And people with learning disabilities will. I've never forgotten that.
That's right.
And my son today was sitting on the set. I haven't seen him do that before. And he was ranting and he was laughing. And I thought, I hadn't seen this. So I don't, and there was nothing like television to say, oh, he's laughing or something like that. There's my phone.
Sorry, no, it's all right. It's all right. Right, so just so that I can capture that just quickly before you come in, just really quickly. There's an issue about social prescribing and the work around social prescribing, and there's also an issue about the length of time that you get seen by your social worker. I think that's fair to say. I would hope that that's an anomaly, but I don't know, so that's fair to say. And you were going to say?
I was just going back to the question about the GP. I would say, again, from experience, probably not the GP. If you had somebody that had mental health specialism in the surgery, would be much better placed.
Yes.
Because they can keep up to date with all the changes in the services.
Yes.
And have the, where the GP are obviously trying to cover so many things. So for me, an identified mental health person, again, then you can see the same person.
Yes.
With a GP, you're seeing different.
Yes. No, I take that point. I think that's part of what's been worked through the strategy. I'm not going to that's what's been worked through the strategy. But nevertheless, it's important because I don't always think, and I say this having not seen my GP for quite a while, I don't always think the GP is the right person to see for all of the things that you need to go to the GP for.
And also, GP practices work slightly differently.
Yes, they do.
So some will have mental health workers within them, some don't. So again, if there was a bit more coordinated way of working.
So better coordination, a better way of communicating the services, both at primary care level, secondary care level, and also, and I use the word tertiary, meaning third. And that's mostly the voluntary sector and the private sector, providing an element of support for the work that's going on around mental health and then disability.
I think a real effort to get the clinicians to stay in post for a significant period of time would also be extremely helpful. You do get fed up of seeing a different clinician each time and having to go back and go through everything all over again and relive the traumas again and again and again.
Yes.
And, when there's somebody in post as a locum, why are they not then appointed? It just seems crazy. They're good enough to be the locum, so then why can't you just then appoint them and then there's continuity? The number of people that I've spoken to over the years is just ridiculous. I think
that there is a real argument about continuity of practitioner. I think absolutely, and I think the other bit about that, I think it comes up again in lots of conversations with services and carers, is the amount of time they have to tell their story. And sometimes it feels like you're just telling the story for telling the story's sake, and it's not resonating or having the kind of impact or effect on it. I would imagine so.
That was the point I was going to make about the refugee going through welcoming between or something.
Yes.
And the amount of times he says he's completed the same set of questions time and time again, and for him it becomes so frustrating. That's added to the difficulties and then not feeling you've got the right support.
Yes.
So how can that information be passed on, like you say, so that information doesn't need to be, it's even the same information is repeated. And maybe there needs to be an update, obviously, because things change, but not of the initial bit.
No.
And then the transitions between services as well are absolutely appalling. If you move, then actually you're going through a stressful situation, and then suddenly all your healthcare disappears.
So I imagine
you're back at the beginning of the queue, waiting again, and you have no support in that time.
My own experiences, there is no follow-up at all. You might go into a crisis, and there's no follow-up. So I think sometimes I question the ability, particularly of psychiatrists, to actually help people. I begin to think
when you only see them once
service.
and then pass on to somebody else, it's pathetic. You can't really help.
So I suppose that what we're hearing that, and I think that's really important to hear that, and hopefully it resonates. But it's also important for us to think about what would help with that. So what would help with the transitions? What would help with that sharing of that information over and over again? What would help with your feeling of not being followed up with the GP? So what would the GP need to do to follow up with you? What would make it better for you? And I'll come on to you in a minute. But what would make it better for you?
Well, it's literally just to follow up. It's, I mean, how can they know how, state of people, how they're managing and how effective. I mean, in my own position, I've been prescribed, I've avoided for most of my life drugs, sertraline, and I don't really find it that effective, but I somehow take it.
Yes.
And it worries, but nobody's ever said to me, how are you getting on with sertraline? There's just no...
So there is something about the follow-up, but also asking, and I would say this, asking pertinent questions about your well-being and about the medication that you're on. Because it's about the medication, but it's also about your wider well-being. Is that impacting your well-being? Do you need to try another medication or whatever? So there's a bit about that, isn't there? I think.
To be honest, I'm not a psychiatrist. Psychiatry is second and see. So you do have to try a few things, and most of them won't work for you. And until you hit on the one thing that works for you, it is a finger in the air job. But having different people throughout that process does nothing.
So there's something about consistency for you, a consistency of a practitioner. What about the issue about the transition? So you're transitioning from a different service or a different part of the service.
Particularly, I would say that the transition, because I've been through this with my daughter, so the transition from the children's CAM services to the adult services really needs to be seriously looked at.
Yes.
And it shouldn't be that there's a cut-off date on a child's 18th birthday when they're still at school and they're about to go off to university. There needs to be a transition between 15, 16 and 25.
Yes.
And all people in that age group should be looked at as a person and should be kept in the appropriate service for them. So if they're still in school, CAMS is most appropriate. And then transferring to a new university and a new health team at the same time, that's when everything falls apart. Just at the time when, funnily enough, they're having stress coming from every direction, and that's when all the wheels come off the ground.
So you're advocating for, and I think it's a case that's well made, about having a transitional process that takes the child, not on the chronological age, but as an individual, and where they're at any given moment in time in terms of their transition into adult care services.
So some 16-year-olds who have already left school and who are not interested in school, put into a CAMS unit. And, I think the best CAMS units are based around a school day. And they're suddenly having to do a school day. For some of them, that works. And I think it's great that they're given that opportunity. But if it's not working and they are fighting it, and I have seen this happening, then I think if they're 16 and they're not fitting into the CAMS model, then it should be okay to move them to the adult services at that point. On the other hand, an 18-year-old who's about to go off to university hits their 18th birthday and suddenly they can no longer be in the CAMS unit. And if your birthday falls in September or October and you're right at the beginning of the academic year, that's a whole year where you've got to be transferred to an adult service with no school. There really needs to be some common sense here and some fitting the service around individuals.
I think that's the bit that I like. The bit about fitting the service around the individual and where they're at any given moment in time sounds right to me. I think you'd agree with that, I think. If I just come back to Duke, I didn't want to miss you out as well. Get your name. So Ruth, that's it. You were talking about the shared information, making sure that information, when you tell your story, when anyone tells their story, the information is not just held with the person that you're talking to, although that's a consistent person, but also the information is shared. So if somebody has to come in on that particular piece of work, they have a clear idea of where they're up to. And that person, the person you're caring for, does not have to repeat the story again. And I think that's been said quite often about the fact that how exacerbating.
He's had to repeat it in the same service, so that even though information has not been shared to a different service, I understand that's more complicated.
Yes.
Even in the same service. But I know when you can sort of talk about passport.
Yes.
So your information, you held something with all your information that you could take. I think that would be very
well. It's worth. I don't know if it's not been said, but if it hasn't been said, we could say it today.
I think something. But
I think learning disabilities have something like that, don't they? Where you take your history with you almost, and so you don't have to repeat your story infinitum. Your history's there really, and I think that would be good. I think actually that would be good for all people. I can't think of anything more frustrating than being asked for the 10th time something about yourself that you've been articulating quite well.
And the IT systems in the NHS are not supportive of the staff. You know, I've had to go into the psychiatrist's own files to help them find things because they've inherited it and they haven't a clue where to look. And then I've been saying, oh, well, I think it was about January 2017, and we've had to go in and sift through together. It really needs to be.
What's that about? That's about better information governance and a way of navigating information, isn't it? Really, isn't it? I think. I mean, I would agree with you.
And recording and storing it, it's the IT systems that record it.
You mentioned, I'll just go back to something that was mentioned earlier because I thought we didn't want to miss it out. So there was something mentioned about workplace support, workplace well-being, making sure that the workplace is a place that you can talk about your physical health issues, but also your mental health issues, mental health champions. Now, I do know that some environments do have a mental health champion, designated mental health champion, that's either done the mental health first aid course or another course that allows them to be able to support the individual. I also know that some organisations have an opportunity for you to get some counselling and support through their, what's the word for it, employment assistance scheme. I think we've got one as well. So we're always making sure that just because we're a mental health charity doesn't mean that we know all about mental health, and that we need to be able to give our colleagues an opportunity, if they need it, to talk to someone in a confidential manner about some issues that may be affecting them. And it may not be issues to do with work, it may be personal issues that impact on their work, such as finance, relationship, moving house, for instance, is a big one as well. So I think that it's really important that when we look at workplace, we make a case for mental health champions, or well-being champions is a better way of describing them. So you're not just looking at mental health, you're looking at the whole person and thinking about the well-being of the individual would be a much better way of doing that. In the same way, go on.
I think there's a really good case for having a lot more peer support groups. And not, just the IAPT, let's do more mindfulness or more CBT or whatever, but actually having peer support where you bring groups of people together who have similar issues and can help each other with how they have coped with things and supporting each other. I think at every stage in your life, when you're a young mum in particular, you need other young mums around you to help you get through that stage. When you're somebody who's looking after elderly relatives, you need other people in that state. And I think that a lot of the mental health issues that cause people to crumble are the sort of family issues like that, where actually a peer support group would probably be a lot more help than a CBT course or any of the other IAPT courses or medication. And I think we're not good at getting peers together and supporting each other.
Well, certainly from a viewpoint perspective, I would be, and I think it's true to say, very positive about peer support, because I absolutely believe in peer support. I believe in the capacity of people using their lived experience to change the lives of other people. So that bit for me is a given, I would say. I think that if you put peer support in the context of a overall wraparound service, so it's not just about peer support, but actually it's about the medications, about CBT if you need it, or anything else you need. If you have it as part of a wraparound service, it is both meaningful and productive for the individual. And I'm not just talking about the individual that's getting the service, I'm talking about the individual that's delivering the service, the peer support worker, get a lot out of being peer support workers. So I agree with you. And I think that part of this new strategy, I would hope and I would think, would not only have a bit about the workplace well-being, but have lots about peer support, about the value that peer support can play in health and social care. And I'm again not just talking about peer support in terms of mental health, although we are here for mental health. I'm talking about peer support in terms of cancer. I'm talking about peer support in terms of diabetes. I'm talking about using people's lived experience to support another person. I think there's a real value in that, I think.
I think that's enough. So we do peer support when we've got something diagnosed, but there's something about, we might not call it peer support, there's about peer support for preventative mental well-being as well. So those anxieties and stresses which are part and parcel of common day life, but problem shared is a problem halved, all that kind of stuff. I don't know how much we've actually got nowadays to allow people outside of certain settings to have some of those kind of interactions before they get to the point where they need to diagnose.
Yeah.
Do you see what I mean? Because it would be beneficial even before you realise you've got potentially something that's been diagnosed by a GP or by a mental health practitioner. But actually, there's some of those things could be, if not changed, perhaps softened or mitigated. If as a society we were having some of the conversations earlier. I think it goes back to the point being made by some colleagues online about the destigmatisation. It's great, but there's more to go in terms of people feeling comfortable to have that kind of conversation early on. And the reason I was thinking about it is you mentioned about the young mums getting together.
Yeah.
I mean, I reckon, and I'm not a mum, obviously, but I reckon quite a lot of that is essentially low-level mental health support.
Yes.
Around exhaustion and anxiety and worry and all that kind of stuff. And arguably, that's just a mental health intervention. I mean, it's a social intervention as well, but we sometimes make this distinction between stuff which, once you've been diagnosed, and stuff when you've not been diagnosed.
Yeah.
It's the same, potentially the same interaction, isn't it?
I think so. I think you're right.
I think you could quite significantly reduce our drug spill in mental health as well.
Yeah.
And be more effective in supporting people.
Yeah.
I know that we are just, I'm not doing that advert, so please don't take it that I'm doing that advert. It might feel that way. We're actively going to be running a men's closed peer support group, and that's the challenge, because the challenge is to get men to come to a peer support group. It's not for the want of doing it, because we'll do it every day, all day. It's the challenge is getting men to feel comfortable to come to a peer support group, to begin to talk and explore issues that affect them. I think that's the challenge that we face. But we're absolutely all peer support, and that's the raison d'etre of the work that we do. All our work is done by peers, to be fair.
Well, I think with men, using the mechanisms that are already there, like the men in sheds, but also like sports clubs, getting out into sports clubs and because men will engage in sports clubs, they will engage in things like men in sheds. Whereas it's much more difficult to get them to engage in other peer support until they're in with the crowd. Sort of thing. Without
labouring the point, and I won't labour the point, I'll move on. The point that I think is right. I think that if you give, this is a generalisation, so you have to forgive me for this generalisation. If you give men a task to do, so let's say you say to men, decorate this room. Men will decorate the room, but by decorating the room, they'll be talking about some really personal things that are pertinent to them. You'd be surprised, and probably talk about more personal stuff than probably women would normally. If you say to men, let's have a meeting and you can talk about your experiences. This is your time. We want to hear from you. You'll struggle. And that's the challenge we've got. We've got to find a way that allows men, because it is really important, not just for suicide prevention, but for low mental health issues.
But you have got to remember that men are much more likely to actually commit suicide.
That's why it's really, really, really important for us to be doing work for men.
Somebody up there said something about not waiting 6 months. I think with men in particular, you have got to get in there early, because otherwise, they will have committed suicide.
Absolutely. So we've established, or I think we've established, that peer support is a good thing, alongside a range of other interventions that are being provided by health, social care, and the voluntary sector, and that we need to be able to have that information about what's available communicated to us in an easy way, in an easy, understood way, so that we can make our own decision about what works best for us, and if we're caring for somebody, what works best for the cared for person. We've also said that actually we think in the workplace it's really good to have mental health champions, or at least a conversation about well-being as part of the working environment. I'm going to give it another 5 minutes, and then we'll have a little break. So just before we break, any other thoughts? Because this has been really helpful. Any thoughts?
About a wellbeing team, which I think in Hertfordshire is a positive thing.
Oh, good.
But I don't think many people know it's about self-referral and still go the GP route.
Yes.
When actually, if that was promoted more, I think people could access things more directly.
Yeah. Could you just
It's about the wellbeing clinic, the wellbeing service within Hertfordshire. I think it has its limitations, but what people are not aware that they necessarily self-refer. So people are still doing the GP route when actually they may be able to go directly to meet somebody and then get signposted.
So how? Just because I know you can self-refer, because I've supported somebody to self-refer to the wellbeing team. I think 2 people. I mean, the forms are quite long and arduous, I have to say. Right. Nevertheless, they're still useful. I won't say that. I've done 2, I think. Could you just tell me how you might promote that better? How you might promote that better? Possibly. I'm not saying you have to tell me. I'm just saying.
Yeah, I'm not really sure. But
are you talking like the new leaf?
No. There's a wellbeing team, isn't there?
Yes.
Which is where GPs usually refer people to the preferred thing.
Yes.
That's where you go to.
Yes.
So most people are going by GP to it, but I think it just needs to be out in the general public.
So an idea would be.
However.
So an idea might be that actually, if we think about it in the way the collaborative thinks about it, that all of us have a responsibility to share that information on our platforms or through our information that we share with our members and stakeholders.
You wanted to reach out to people who don't know about your platform.
No, well, I see, this is the other bit as well, and we'll come to that. I will come to communication, because communication is a big thing.
Because it's actually, I think that I've really experienced, I'm struck in Hertfordshire, how all the official NHS services tend to be in the west of Hertfordshire.
Ooh.
There are a lot of people that don't even know what Viewpoint is.
Yes.
And, mental health workers don't even know. I was quite shocked because I know somebody who was a Labour councillor within the local, for Welling and Hatfield. He had never heard of Viewpoint. And a lot of the other charities, it's as though they're just scattered. They're not coordinated. And you can't go to a library, you don't see any notes about mental health or even supermarkets. It's fragmented badly.
I won't talk about Viewpoint past it, although I take on board what you're saying. I think there is an issue there, but I don't think we're the only ones. But I do think there's an issue there. And it's really an issue about how we communicate the service that we provide for people effectively, how we get more members on board, because our members are our power. And if we have no members, we have no power. So the more members we have, the more power we have, the greater our voice. And we're always saying that. So, and it's about word of mouth as well. So if somebody doesn't...
It's about names as well. I mean, you said to me, I remember a Viewpoint, and I didn't know.
Yes.
It's...
Yes.
It turned out I am,
Yes.
But if you name things aptly, and then people know what to look for, it's back to the Google search. How can I get help with? If it's properly, easily labelled, then it's not too accessible.
I would say I think Viewpoint is properly, easily labelled, but nevertheless, I hear what you're saying. So I don't want to labour the point, because this is not about Viewpoint, although at some point it will be. And I take your point as well, Michael. What I would say, the greatest power is the word of mouth. It isn't the internet. It isn't what I post out. It isn't any of those things. It's what I say to people that resonates most with them. So what I'd say to all of you, you all know Viewpoint and you all know what we stand for. or at least you will know what we stand for. It's important for you to convey that message, because it can't just be me and it can't just be my team. It has to be all of us taking our own responsibility to convey the message of Viewpoint. And then the other mental health charity. Mental illness is as important as physical health, parity of esteem, and we just need to make sure we raise that as much as we can. Right, so on that wonderful stirring note, I'm going to call a break, and then if we aim to be back here about 2:55, that should help us through, and then we can have more time for discussion. All right, thank you all. Brilliant.